Good afternoon, everyone, and welcome to this PCR webinar on preventing and treating acute heart failure in STEMI patients. So the learning objectives for this afternoon are going to be describing the pathological mechanism underlying acute heart failure in STEMI, identifying STEMI patients' phenotypes with heart failure who might benefit from mechanical circulatory support, and to explain how left ventricular unloading with Impella CP prior to primary PCI might reduce infarct size. So I'm in with a great company this afternoon. On the right, I have Professor Jan-Malte from Cologne, Germany. And here I have Dr. Vasileios Panoulas from London, UK. Welcome, both. It's a great pleasure to have you here. You're both great experts in these fields. And before jumping into discussion of this afternoon, let me spend 1 minute to pay a tribute to a giant of cardiology, a pioneer of, let's say, cardiology of modern era. He was a man who very contributed to the field of cardiology, but particularly he did a lot of research into hemodynamics, heart failure, cardioprotection, how to prevent infarct size. He passed away a few days ago, Professor Eugene Braunwald. I think we both studied from his books. And so having said that, let's learn from his lessons and let's jump now into discussion. So we know that cardiogenic shock is a serious complication of patients presenting with acute myocardial infarction. So how can we prevent this complication? How can we reduce mortality of these patients? Jan-Malte.
Yeah, thank you very much, Valeria, for this kind introduction. Dear colleagues, I would like to start with the first part of this webinar, talking about acute myocardial infarction complicated by cardiogenic shock. And I would like to start with a case from clinical daily routine. A patient who presented to our hospital was 70 years old, had the usual comorbidities such as arterial hypertension, hypercholesterolemia. He was an active smoker. And as he presented to our hospital, his cardiac history was more or less empty. He never had any issues, but he presented now with a really significant severe chest pain with an onset 3 hours ago. His blood pressure was 90/60 millimeter mercury, so quite decreased. His heart rate was elevated, something between 100 and 110 beats per minute, and he already had a lactate of 2.6 millimoles per liter. So actually, regarding the SCAI classification, we would classify this patient as a cardiogenic shock, SCAI stage C already. Non-surprisingly, he had a 12-lead ECG with significant elevation in the anterior wall leads. And this is his angiogram. We start in our institution traditionally with a LV angiogram. We can appreciate the severely depressed LV function with an akinesia of the anterior wall. We have a large right coronary artery, and also non-surprisingly, the LVDP was significantly elevated already. We had an LVDP of 24 millimeters mercury. And taking a look at his left coronary artery, we could appreciate on the one hand side the culprit lesion, the occluded proximal LAD, which already looked quite calcified, maybe with a thrombotic component. But on the other hand side, we can appreciate an ostial lesion of the circumflex artery reaching a little bit into the left main, so that also looked quite severe. And what is important and always is something we would like to know before we start deciding which treatment strategy this patient has to undergo is to know more about the excess vessels. As we're doing most patients radially, we did just a quick shot into the iliac arteries. And now the major question is how to treat a patient.
Great, Jan-Malte. That's an excellent case, very interesting, very complex. So we have the first poll for our audience. Please submit your response because we want to know how you would treat these patients. So we have 5 options. We perform primary PCI with no support. You will ask the surgeon to perform a CABG. You will perform primary PCI with Impella support up front, or Impella support as a bailout, or with ECMO support. So in the meantime, we discuss also with Vas. Vas, this is a very complex patient. How often you see these patients in your clinical practice?
I think this is a double complex patient because not only you have the hemodynamic element of cardiogenic shock, but you also have this very complex anatomy. So you're faced with a patient that is very sick from a pump failure perspective, but then also, you know, when you go in there, you have to deal probably with quite complex lesions. And I mean, we can discuss what to treat and if to treat, but when I saw your coronary images, my heart rate went up a little bit. So is these patients, are they quite frequent? The reality is they exist, but they're not as frequent as we think. Particularly when we start talking about the blood pressure cutoff, less than 100, less than 90, they are very few of these patients because often we know that a lot of them can compensate because of their innate adrenaline rush, and nature wants the blood pressure to be the last thing that drops. And often when that happens, we're in a free fall situation where, you know, we're in a salvage procedure basically. I don't know what's your experience, Matt?
Yeah, absolutely. I agree 100%. Whereas these patients are rare, and as you said, not only his hemodynamic situation is quite complex, but also the coronary situation seems, at least at first, quite complex. And of course, we could focus on the culprit lesion only, but as we will see in a second, we don't know what might happen and what is this other lesion about.
Okay, so we have the response of the poll. So I would say that the majority went for primary PCI with Impella support up front, but still we have 23% of our friends from home saying that they would embark in the primary PCI and then consider maybe Impella as a bailout. What did you do?
Yeah, I'm glad that the majority decided as I did in this case. And now we have also evidence that this is for the first time an option which is covered by a study that was published recently, 2 years ago, presented at ACC, the Danger Shock Trial, a study that recruited more than 300 patients and was able to show that mechanical circulatory support in cardiogenic shock patients with STEMI and certain inclusion criteria showed a clear and significant survival benefit, of course, at the price of more complications, but with a clear net gain. So we had a number needed to treat of 8 patients and an absolute risk reduction of 12.7% in this study. So we, non-surprisingly, implanted an Impella CP Smart Assist in this case. What is essential, and we are talking about in a second as well, is to do an echo-guided puncture of the groin, of the femoral artery. That's something that is a must. We have learned that from TAVI, and we should never puncture a groin for large bore access without ultrasonography. And then we started the procedure with a 7 French EBU 3.75. And interestingly, saw that the blood flow in the LAD increased again significantly, I would say TIMI 2 to 3, even though this patient was already on 10,000 units of heparin. So is that something, Wes, what we see very often in our routine? What you say in your practice in London?
Yeah, I must say it's a very interesting finding, and we will discuss it a bit later on in our series today. But indeed, there are some patients, I don't know, I would take a guess from my experience, probably 1 in 8 or something like that, that they suddenly you see reperfusion before you even touch them with any coronary wire. And I think that could be a combination of your unloading device, but also it could be the fact that your anticoagulation is starting to work. So we don't really know. I don't think we can make definitive conclusion, but it's definitely something that we see happening in cases that we implant the Impella device ahead of the PCI itself. And to be honest, when you see this picture, you're terrified from the anatomy that you're looking at, but also you can take a breath because, you know, the area is now revascularized and is having blood flow. So you have achieved your door-to-balloon time without a balloon. I mean, that's a new concept. Auto reperfusion, yeah, with a device.
No, but you made a very excellent point. Now you can breathe
As an operator.
and plan the procedure, because this is a very complex procedure. When we look at the anatomy, we see calcified lesion at the level of the LAD, at the proximal LAD, but we also see some haziness at the ostium of the circumflex. We don't know if there's thrombus, if there's calcium there, calcified nodule. I mean, this is a very complex anatomy. So, Jan-Malte, what would you consider as for this patient? What did you consider? I will ask first the audience. So let's open the second poll. Primary PCI of LAD, primary PCI of left main circumflex, of multivessel PCI of LAD and left main circumflex. What were your considerations in planning your procedure here?
Yeah, as both of you nicely pointed out, as blood flow increased significantly in the LAD territory, again, this patient was more or less free of pain, was not suffering anymore so significantly from angina, and improved, of course, also hemodynamically, so that I had the time to focus on the procedure. Of course, we're doing these procedures with intravascular imaging, but as I was afraid that this probably thrombotic lesion in the left main circumflex territory might make me some trouble. And also, if this is a thrombus, you can embolize the thrombus wherever too, and then the patient is really deteriorating. I decided to use the Impella as I did, and I'm interested to see what the audience recommends. Of course, I had my treatment plan.
Well, I have to say that, we have really conflicting results. We have 56 of the audience saying they will go only for primary PCI of LAD, 15% PCI of left main circumflex. So there's something going on in that ostium of the circumflex that we want to tackle, to address, and 30% saying multivessel. And I understand that because we also learn from trials, we learn from the shock trial that we should go for culprit-only PCI, but that was a different setting of patients. Now we have also some data showing something different.
Mm-hmm. Yeah, and I'm again glad that the audience decided not the way I decided, because then we have something to discuss. And I just quickly want to highlight one sub-analysis of the danger shock trial in this situation. This is, of course, a population where we don't know which patient underwent which treatment, but we can see clearly that culprit-only PCI had a higher mortality than immediate multivessel PCI. Of course, these data are only hypothesis generating because the trial was not powered for this sub-analysis, and we know from Holger Thiele's shock trial, culprit shock trial, that we should focus on the culprit lesion only. But again, having said that, we know that in this trial, several CTOs have been treated. This is not a CTO situation, it's a high-risk situation. And I decided to fix the LAD to understand what's going on in the territory between the left main and the circumflex artery, so that there will be no opportunity for the patient to deteriorate again when he's on ICU with the Impella, and decided to treat both arteries. That was quite easily achieved, and interestingly, even though the angiograms look a little bit different, this calcium was not so severe that I needed some calcium modification strategies other than non-compliant balloons. I implanted 2 drug-eluting stents in the LAD and 1 as a provisional stenting left main circumflex with a kissing balloon inflation final pot. And you can already see on the right-hand side the final result. And here again, the final result after IVUS check. And with this beautiful angiographic result, the patient went to our ICU, was completely stable, cleared the lactate immediately after the cath lab. What I didn't tell you up front is that we tend also to use a ProGlide, or in these days Pro-style device, for pre-closure of the groin, at least one device. And even though time pressure is sometimes there and we have to hurry, there's always the time to put in one closure device. And if that is not enough, we use another angioceal 8 French, as we did in this case here with a controlled angiography. In these days, we are also doing this closure at bedside on ICU, so we don't take the patients routinely to the cath lab unless we expect any complications. And this was something we are not doing routinely, but just to highlight in this case how significantly this patient improved after already 13 hours of LV unloading. After removing the Impella, we did with this radial axis, we established in this patient again another LV-EDP measurement and see that this LV-EDP decreased significantly while blood pressure increased again a lot. And this patient was doing fine as expected and was discharged already 3 days later. What I think is quite important is that we have some kind of algorithm. And I think, but that's something we can discuss together, that an Impella as bailout in these sick patients is not a reasonable option. So our strategy in most of the cases is to do, if the patient is presenting with cardiogenic shock and has a hemodynamic problem, even worse with a hemometabolic problem when the lactate level is increased, gets an immediate coronary angiography. And if we decide that this is a patient for hemodynamic support, we definitely put in all of our patients the Impella in pre-PCI. So if that is not enough, we can escalate again afterwards. But most of the times we are able with the Impella CP Smart Assist to keep the patient stable.
It's very important, Jan-Malte, to have a standardized algorithm. Of course, we cannot use the same algorithm in all the centers, the logistics and geographical disparities, but it's important to have in your own institution a way also to communicate, to stratify the patients. So you showed your very nice algorithm. Do you use also a SCAI classification that we know it's something has been also validated in a big cohort and has been recently also improved, adding some variables that can actually stratify the patients even better with the information about the lactates, about the pressure, about the use of inotropics. Do you use this classification to streamline the communication?
Yeah, absolutely. This is a very reasonable tool. And as Wes nicely pointed out at the beginning of our webinar, we sometimes miss these patients that are still normotensive but are already developing shock symptoms such as metabolic problems, lactate increase. So the SCAI stage classification addresses this already. So it's very, very good to use this algorithm in our clinical daily routine. And even the fact that there are some calculators available that are also cell phone based, the nurse outside the cath lab can already calculate whether this is a patient for hemodynamic support or not. So quite easy and straightforward.
And Vas, do you have the algorithm in your institution? Do you use
Yeah,
them?
I mean, it used to be more of a consultant-led, announcement, let's call it. But these days we're trying to formalize it by using the cardiogenic shock working group SCAI classification in particular, because we all thought that this is the one that, and not everyone is going to have the same SCAI class, whether it's calculated by me, yourself, or Malte. And we decided to formalize it, and the nursing staff are taking control of it. And we do it for the patients before they enter the lab, but also at the end of every primary PCI procedure to know where would be the best destination for them. And as you said, it's very, very easy to do, and it's very convenient for the lingo between the different teams. And obviously, if you have a patient in SCAI C like this one, sometimes the pilots don't notice, and then at least you have the warning sign from the cabin crew or the co-pilots that can always raise their voice and say, this patient's in shock. Can we please consider potentially MCS or get the shock team involved? I think it's super important, and we learn from aviation a lot, and I think we should also learn the human factor issues in our cath labs. So we're now formalizing it, and I think it's going to contribute a lot more better outcomes compared to what we have.
And do you think we can use also this algorithm to identify those patients who are going to benefit from the support, MCS support? So we look at we watched the case from Jan-Malte, actually an excellent danger-like patient. He has all the characteristics of the groups, indeed, which in the study, the subgroup analysis showed that they had the most benefit from the support. So male population, also the age, hypotensive patients. So can we use this algorithm to identify those patients?
Yeah, so I think the danger, in fact, classified its patients based on that cardiogenic shock working group, SCAI tool, and it identified that 55% were SCAI C and the rest were SCAI D and E. So I think the moment you identify someone in SCAI C, all you need to do is a quick checklist of the danger shock criteria that, as you've shown, is very, very simple. It's like a blood pressure under 100, lactate more than 2.5, and ejection fraction under 45%. And of course, look a little bit at the contraindications. Where I think the difficulty comes with the teams is when you have these patients that have had cardiac arrest and come to you with not very long downtimes, but they're intubated, so you cannot really assess the neurology. How do you then decide whether to go on support or not? And in our institution now, because we also work closely with a team that created the miracle score, we tend to apply the miracle score. And if it's way above 3, 4 plus, then probably we approach a little bit more conservatively. But if it's 3 or below, have a decent neurological potential outcome, then we deploy devices. So I think that's another population that is not really studied, but I think we have to somehow identify a way of working around it. Similarly is the higher age. I mean, with danger, we showed that under 77, the number needs to goes down to 5, which is for me one of the most remarkable findings in studies recently. But then equally, you don't want to be necessarily ageist in that sense. So we haven't, as an institution in our protocol, we haven't set an age as such, but we use the Canadian Frailty Score as, again, a marker of trying to understand, who would benefit from the device. But these are nuances that in day life you come across and you realize that, randomized trials is one thing, and then you have also the real life.
Reward. Yeah, absolutely.
Yeah.
And Jan-Malte, in this algorithm, you also have the use of Schwann-Ganz in order to have an invasive monitoring of hemodynamics. The case you show, the patient indeed had a very nice drop of LVDP, also associated with a fast clearance of lactates. Something that you do routinely? Do you think there's an advantage of doing it?
Yeah, that's a very good point, Valeria. I mean, obviously in this patient, we didn't use a Schwann-Ganz catheter, but even though we didn't treat cardiogenic shock patients for the PROTECT 4 trial, we learned a lot in this right heart catheterization sub-analysis, even though the results are not published, but we participated in this trial and saw how significant Schwann-Ganz catheter can impact what you're doing with your patient, because you not only see indirectly the LVDP by measuring the wedge pressure, but you can also appreciate cardiac index, cardiac output, and that is quite helpful, especially on the ICU, to decide when the impeller can be weaned, when it is maybe time to escalate, what is very rare, but in these situations, under these circumstances, a Schwann-Ganz catheter might be very helpful.
We have some questions from the audience, and that's, of course, something we might expect also because of some restrictions. And there's a colleague from Indonesia asking, would you consider balloon pump in this case if you don't have access to Impella?
Yeah, that's a very good question, and I'm glad that you asked it, because I'm doing a lot of PCI also in Vietnam, because we have a friendship with Vietnam, an exchange program, and we're doing a charity trip every year for at least 10 days there, because my EP colleague, he is originally from Vietnam. And at least in Vietnam, I don't know the situation for Indonesia, there is no Impella available, at least so far. Although I hate to say that, in Germany, intra-aortic balloon pump is not available anymore. So you will find it in none of the cath labs. To be honest, we have data from the PROTECT-2 trial, which is really old-fashioned, I would say, and it's compared the Impella 2.5 basically with the IABP, and we learned that after 90 days in a secondary analysis, there was an improvement, there was a significant benefit. It's hard to answer this question with clinical evidence. If I have the choice, I wouldn't use an intra-aortic balloon pump because we have more evidence, registry data, recent registry data for the Impella, which is the only device available on the market. But if you don't have anything else, I would say the intra-aortic balloon pump is better than nothing. But again, to be honest, we don't have any data for that.
With some hemodynamic consideration as well. Another question about bleeding. I mean, these large bore access devices, sometimes we pay the price of a higher bleeding risk. What's your strategy? Which tips can you give to the audience in order to minimize the bleeding risk?
Yeah, that's a very important point, because if you're not doing TAVI and you're not used to handling large bore access, this can be a challenge. I would recommend to be familiar with pre-closure, especially ProGlide or ProStyle. That's the easiest, most inexpensive way. Manta is a very nice option, which is more or less like a large angioseal. And what I think is the most significant predictor of bleeding complications, doing a pre-closure with a ProStyle and ProGlide after echopuncture. Echopuncture first, and then that's something we know from several cases, that there's a constant, very slight bleeding. But if you're doing pre-closure with a ProStyle, you can pull the suture a little bit, and then most of these bleeding issues will be solved. But I cannot highlight anymore. I cannot highlight more that echopuncture is the most significant part, and really is a game changer when you do it.
Vas, do you do pre-closure standard also in cardiogenic shock patients?
Yeah, we do it always because of two reasons. I think one is obviously the ease of removal at the end when you want to either escalate or wean, but also the fact that the current design of the Impella CP has a larger peel-away sheath and a smaller reposition sheath, so we tend to put even two ProStyles. And before during the exchange, so when I remove the peel-away, I tied down the knots without locking them, and then I put the repositioning, and that has really changed our practice in a big way. But I think also we need to highlight the differences in anticoagulation practices across the world. So I think everyone does kind of their own thing. But what we have found, and also we're working with leading experts in the field, is that anti-10A and ABTT combination works the best, and we find that anti-10A is a bit more reliable in these patients. And we also have found that in the past we used to anticoagulate these patients, and we had these bad rates.
Jan-Malte, one more question about the danger shock. Maybe a provocative question. Has the trial changed your practice?
Yeah, I mean, as you might have already noticed, I'm a believer of mechanical support in cardiogenic shock patients. But to be honest, it's the first study really giving us some evidence that we're doing something beneficial for the patient. So it, first of all, reconfirmed my practice. And now, as I know that at least STEMI patients with ongoing cardiogenic shock significantly benefit from mechanical circulatory support, I try to identify my patients earlier. And even though we only have sub-analysis so far, I tend, as I implemented and showed in my algorithm there, to look for other parameters such as the LVDP, for example, lactate level and so on, to identify patients who are at risk and that would benefit from circulatory support, even though we are just creating evidence for these patient subgroups at the moment.
There is some question we have been left with after the result of the danger shock, that we saw a benefit in terms of mortality for the MCS support group at 6 months. But we see also that the two curves, the Kaplan-Meier curves, from 30 days to 6 months, they continue diverging. And one might expect that the support of MCS is very beneficial during the first days, during the intensive care stay of the patient. So do you explain these further benefits because of the MCS device, or are other explanations for this?
I mean, to be honest, I don't have the 100% explanation for that. It's just some speculation or gut feeling, if you want to like that. So maybe by using MCS, we're decreasing infarct size, which might have an effect on the development of heart failure, as we will see in the second part of our webinar when Vas is talking about the STEMI DTU trial. And I think these effects we cannot really identify with data we have so far. These might play a role. And I think it's again, some kind of heart failure treatment we're doing, maybe reducing infarct size, but that's something that has to be proven by hopefully future upcoming studies.
Thank you so much. And I think that's a great answer, because that's open also the discussion for the next trial we want to highlight. We learn indeed that infarct size is associated with mortality long term. That's a certainty that stay with us. We are getting better at reperfusion time, door-to-balloon time, but we have to deal with the fact that these patients with big anterior MI especially, they have a large infarct size, and that will impact on heart failure risk and on their mortality. So,
absolutely, yeah, and I think the long-term results of the danger up to 10 years basically suggest that we're doing something right in terms of reducing this heart failure burden, and potentially they have better ejection fractions, but we can't really prove it. But what we know for sure is that one of the strongest predictors of heart failure, as you said, is death after MI, is infarct size. The bigger your infarct size, the more likely you are to drop dead and have heart failure in the future. And we also know, we found out 15 years ago that even if you get that door-to-balloon time below 90, it doesn't really make a big change in mortality. And we mentioned a little bit about, particularly in people above the age of 65 with their first acute MI, you can see that despite having a fantastic reperfusion, excellent door-to-balloon time, you still have a big 10% in hospital mortality. You have 34% in hospital heart failure, and a big chunk of those patients will end up with heart failure in 5 years. And really, infarct size matters, and also the bigger infarcts, the anterior infarcts, are the ones that contribute tremendously to this burden. And obviously, it comes without saying, we've all been taught during our medical schools that time is myocardium, time is muscle. Constantly, that's all we hear, and this is based on these curves. And I think they're absolutely right, and we all try our best to be as fast as possible. But then some demographic studies have shown that even though we get below 90 minutes, even if you go from 80 to 70, let's say, or 60 even, that mortality at some point doesn't shift anymore. And we see that in different subgroups, as you can see in this slide. Despite all of that, and even the cardiogenic shock group, as you can see in the bottom right there, despite getting those fantastic door-to-balloon times, you cannot really shift that mortality, that just stays there. So if that's not enough, the obvious question is, what else can we do to protect the muscle? And I guess the logic answer is we try to reduce the energy consumption of the heart during these bad times for the heart. So, and one graphic way of showing it is that area under the curve of the PV loop, which for every heartbeat, you want to have less area. And we know that this Impella pump does this reduction of the area, so the stroke work of the heart is very reduced when you have a pump. But obviously, with every heartbeat, that happens. So you also want to have less heartbeats. So it's also important to introduce the concept of trying to reduce the heart rate. And then, is that something we found out recently? No. I mean, if you dig in the past, you see very clever people all the way back in the 70s here in animal models showing that you occlude the LAD, but you have a transvalvular pump, and the unloading really helps, even to resolve ST segments. And a lot of people have done trials in animal models to show that partial or total LV unloading can reduce the infarct size, and again show that there is signaling pathways that become cardioprotective when you actually use unloading. And most interestingly, I really enjoyed this publication that showed basically that compared to ECMO or immediate reperfusion, an LV unloading strategy actually really seems to work well in reducing the infarct size.
So I think you showed very nicely that the rationale for the STEMI DTU trial is based on an extensive research, preclinical research, because the attempt of reducing the infarct size has been very hard, using all kinds of pharmacological but also preconditioning strategies. we know that what we do with reperfusion is opening the vessel, but then we induce an injury as well. So what we want to do and that's based on, at the cellular level, of increased calcium overload. So what we would like to do with unloading is reduce this increased calcium overload, inducing a functional kind of reperfusion. But it has always been so difficult to translate then this result from preclinical models into clinical practice.
Absolutely, and also, the big question is like how much do we need to wait with unloading before we open those vessels? And because a lot of people before STEMI DTU were always asking that question, why are we using half an hour? It's not acceptable in our practice. Why 30 minutes? But it didn't come up in someone's head to do that. I think there was, as you mentioned, years and years of clinical and animal model experimentation that showed, as you can see here, that immediate reperfusion alone or reperfusion 15 minutes in the animal models didn't really work, or even unloading after reperfusions didn't work. That's for the people that are the kind of bailout kind of strategy. What really worked in those animal models was that 30-minute unloading and then reperfusion. And that was the beauty of STEMI DTU, that actually took the whole science from the animal model to an original study of a few patients, as you can see there in a pivotal trial, that showed also no harm if you unload if you do the immediate unloading and reperfusion versus unload first and wait half an hour and do the reperfusion, just to reassure people like you and me and Malte that nothing will come to harm of your patients if we put them into that trial. So it was a really, really well thought trial. But yeah.
Yeah, but for us as interventional cardiologists, we learn that time is muscle. Eugene Braunwald, we have to open the vessel as soon as possible. That's a lesson we learn. And then, how did you get into this trial? When did you decide that, okay, I'm going to be an investigator for this trial, being this very counterintuitive from what we learn?
That's very true. I mean, you hear a lot of evidence, but if you've done, you're doing 100 primaries a year and time again, you see those patients get better if the faster you open the vessel. A lot of cells of your body are fighting against waiting half an hour. But then you also have to have this aha moment in your life. And for me, it was one case of a CTO that I actually did it up in Dundee with a spectacular CTO operator together. And the first time they tried to open up this LAD using epicardial collateral, they blocked the flow to the LAD. And basically, this is the ECG of that patient with a blocked LAD the first time without an Impella device. And you can see massive ST changes, and the patient was screaming in pain. And basically, I was asked to go and help out and perform that case with an Impella support. And on the second time around, you can see we performed exactly the same maneuver, occluded the LAD, create, let's say, an anterior MI circumstances. But this is the ECG that we saw, and the person was just sitting there and didn't complain at all. So for me, that was like, oh, okay, actually really works, this device. So maybe I should just, take part in this trial. And I think that's when it comes to then, considering to subject our patients to the STEMI DTU pivotal trial, that it was a trial of anterior STEMI patients, and you can see there the inclusion criteria, but mainly was basically anterior STEMIs that were not in cardiogenic shock. And you needed to show that there was an anterior LV worsening abnormality with an LV gram on an echo, and you need to show a high LVDP and feasible anatomy for the implantation from the iliofemorals. And you had the two arms, so you had the Impella arm where you just went in and implanted Impella, and you didn't take any pictures. You just literally were there with the Impella waiting for half an hour. And then the other arm that you would just do your thing, you would just go and open the vessel. So for me, that was quite an experience, I must say, because obviously, what do you do for this half an hour? You're just there and sitting and watching. Would you like that?
well, did you have to check on the patients? That's the point. Did you have to check for more hemodynamic support or the patient having pain?
I thought it could be a very stormy 30 minutes. So obviously we were all scrubbed and stuff, but actually it was the most relaxing 30 minutes of my life. Sometimes too relaxing. I was nearly falling asleep because the patients, all of them, their pain just subsided, and in some of them just completely resolved. And in a decent number of patients, also the ST segments were coming down. So And in fact, I think we will highlight it later, but I think it's worth saying now that in the trial, there was no bailout PCI during those 30 minutes. So that kind of shows the impressive power of the pump during this time.
The operators were confident indeed waiting for the 30 minutes.
And they were not forced, I guess, because if you have a VT storm, probably you would say,
exactly.
you know.
That was my further question about the ventricular arrhythmias in these patients.
That is the impressive element, that you know, no operator was forced to go ahead and do anything. So it was a very stable scenario. So I'll just show you a couple of cases, and they were both included in the study. The one on the left was randomized to the study, the Impella arm, and the other one to the conservative. So you can see, you know, ages, you know, 65. The first one was smoker, diabetic, classic risk factors. Very quick from chest pain, 1.5 hours. The other one, nearly 3 hours. And then you can see their ECGs, you know, proper anterior STEMIs. You can see their echoes, again, proper LAD infarctions, both of them. And hemodynamics. And this is an interesting slide because I think when you hear someone telling you, you know, include all the patients that do not have cardiogenic shock, and then you go, you know, yes, hemodynamically there were both, you know, 110 systolic. So operator-wise, no sweat, nothing really to worry about. But then you go and check their blood gases and you see, lactate was, you know, 2.1, 2.2, even with this kind of pressures. So that was kind of an interesting message from that slide. And then, you know, when we do the angiogram, so in the first case, we had to wait half an hour. And then you can see here similar anatomies, both of them very classic proximal osteo LAD occlusions. And then classic, nothing, you know, special about the procedures themselves, but just both reopened with a wire and ballooning and got decent flows in both of them. But one of the things we didn't mention is that in some scenarios you would see the vessels that were opening. I think we mentioned that with Malte's case. And for me, from this study, I was very keen to know how many more tend to get open. But we'll discuss that in a little bit. And here you see the final results on the MRI.
Great that you found 2 cases, both included in the trial, and one randomized to MCS support and the other not.
Yeah, I mean, these are their echoes, but this is something we see in clinical practice all the time. And then we got the MRI scans, obviously, at 3 to 5 days, and you can argue, you know, equally there's a decent area of myocardium that has been hit, and with the gadolinium pictures, again, you see a lot of scar coming up all the way. But then, in terms of the study endpoint, it was mainly focused on the infarct size, 3 to 5 days, and you can see those secondary effectiveness endpoints.
But the trial was kind of selective. I mean, we had 70 sites participating, and I mean, if you see the number of subjects screened, and then the randomized, I mean, the ratio is very, very low.
Yeah, I mean, you can see there is nearly 1 in 8 or something like that.
Yeah.
But I must say I found it personally, at least, much easier to include for the STEMI DTU than for danger, because I've included for both, and I have to admit that I could put a lot more patients in this trial. There were more, and we see that often. You know, a lot of these anterior STEMIs, they hold their pressures, and despite that, they hypoperfuse a little bit. And here you can see in their baseline characteristics that exact element where you see their systolics, 140. I don't know, Jan-Malte, do you think that was high for them? Were you impressed with that?
I was absolutely surprised that the LVDP was so high in these patients. I mean, as you showed, both had more or less osteo proximal LAD occlusion, and I'm sure these patients were really suffering from their hemodynamic condition. And as well, the LV function also was quite decreased, so a mean of 45 is not so high. I thought that, let's say, less sick STEMI patients would be involved in this trial. So these are really patients in maybe a developing shock, normotensive shock, however you would like to call it. And again, the SKY stage classification might help to identify patients that would benefit from hemodynamic support.
Yeah.
Yeah, we should not forget, of course, that the SKY is a continuous spectrum. Is not that the shock identify discrete stages. I mean, these patients evolve very rapidly. But what I think is important is also to underline that, the LVF, as you were saying, was quite high. So Maybe not all of them were proximal LAD with a large territory. Maybe there were some mid LAD also involved. And I think also the blood pressure, the systolic blood pressure is quite high. So these are basically hypertensive patients with an increased LVDP, so they might develop shock. But when they got in, they had high systolic pressure. So probably the Impella was not working, doing its best.
Absolutely. I think you're very right in these observations. And it's true, a lot of the patients had mid-LAD if you read in the little prints of the study, but the reality is that the Impella works with a pressure differential of the LVDP and the diastolic pressure, and the higher that is, the less flow the pump is going to offer. So basically, probably was not contributing as much, particularly with these diastolic figures in the 90s and mean arterial pressures of the 100. So I think you're absolutely right. And do these patients, because we were discussing, do they exist? And I think here you can really see what we were discussing before, that the danger population, which is the little red box, and that's our experience of 4,000 STEMIs in Harefield Hospital, there's few that you can find, and the majority of them are on the top, and they're like the patients with the high lactates, but despite that, they still keep their little pressure going. And I guess that goes back to nature. But before we asked the question, how many of those patients in STEMI DTU did they reperfuse or let's say recanalize their LADs, for example? And the answer is on this slide. You can see there that pre-PCI TIMI flow of the culprit vessel 2 to 3 was 44% in the Impella arm and 30.6% in the standard of care arm. So just putting the device in was leading to opening the vessel basically in a significant proportion of patients. And that's something I think that was very interesting. And of course, the other thing you see in this slide is the perfusion pressure that was much higher in the Impella arm, despite, as we said, the time being against it. I mean, the other topic to discuss is this prolonged ischemic time, right? So, I mean, we saw in this study was 47 minutes. Would you consider it acceptable, a delay of 47 minutes? I think you would ring your fellow and be very mad at him or her if you had this 47 minutes, no? I don't know, and despite that, we didn't see a big difference here.
Well, we go back to this idea of a functional reperfusion, which has a rationale, at least in preclinical model, we need to understand better. And maybe, Vas, I mean, do you think there are some learning points, of course, from also this trial, which group might benefit the most from this strategy?
Yeah, I mean, I think we're not really animals to say we're going to behave as them to start with. So maybe this amount of ischemic time is too much for us as humans. So maybe a shorter ischemic time might be benefit for us. I don't know if that's 0 or that's something else, but something we have to definitely look at. And then, things, very simple things, as we mentioned before, for the pump to work more efficiently and reduce that area under the curves of the pressure volume loops, you really have to optimize the conditions for the pump. So you want to reduce that mean pressure, you want to reduce this diastolic pressure as much as you can, and you also want to reduce the heart rate. And, I think doing these things, we can actually see that maybe the results of the STEMI DTU, which is what you see here on the screen, may have been totally different. And for me, was quite remarkable that despite that very long ischemic time, there was no difference, and if anything, there is a numeric kind of difference favoring the device treatment. Nonetheless, non-significant. And when you see the per protocol again, you see slightly that numerical difference, and there was no difference in the key powered secondary endpoints. And then, some people may ask what predicts this this ischemic time, and you can see it very nicely in this table. What predicts ischemic injury and infarct size. The longer ischemic time, more heart attack size. The lower your ejection fraction, higher LVDP, the bigger your infarct size, higher lactates, proximal LAD, TIMI flows that are 0, obviously all of that's contributory to big infarct sizes. And then again, I think we just need to point out these literally 2 subgroups that were pre-specified. And I don't know, what is your take from, why would it be a bit
that's
better?
a bit striking, a bit also, something opposite to what we learned from the danger shock, that younger patients will benefit the most from the Impella support. So if there's something different in this phenotype of patients coming in, some level of preconditioning, localization of myocardial infarction. What do you think, Jan-Malte?
Yeah, hard to say, as you already pointed out. I mean, it's just a gut feeling because we know, as you said, from danger shock that especially, and that makes sense in my opinion, that especially younger patients benefit from this invasive procedure. And in this trial, it was completely the other way around, so that patients with a median age of above 60 years benefited more, not significantly, but numerically. Maybe it has to do something with preconditioning. I think we have to understand a little bit better what was going on. And I think also this signal in the sub-analysis regarding beta blocker treatment, as you nicely pointed out, is a clue to better understand what was going on. So maybe if we actively lower blood pressure with beta blockers and other drugs, maybe the effect of the Impella will be even better, and then the patient benefit more. So that's the major question I'm asking myself after this trial.
Yeah, I mean, I can tell you as an investigator, I had the study team on the phone, and whenever we were randomized, they would also push for beta blockers to make sure we optimize the unloading conditions. And I think, you know, the study results really demonstrate that. Like, it's not just, you know, put a pump in and do whatever you like. It's not really like that. You want to really try to minimize the energy that heart is consuming during the post-infarct period. And the only way to do that is to really focus on the hemodynamics, what we mentioned. You have to really reduce that MAP, and you have to really use your beta blockers to reduce the heart rate. I mean, now we also know there's a trial specifically targeting MAP, the Norshock trial that is coming from the Netherlands. And we're really proud to also take part. And I really believe in it, because we all go on about the afterload, but we don't actively do something. And I think hopefully that trial will also shed some light on these concepts that we're now talking about. But
I think we have, like, you know, on one side, the good selection of patients, and that's also going back to preclinical studies. We learned that longer ischemic time, a larger area at risk, these are the patients who benefit the most. And on the other side, we have to also let's say, optimize the hemodynamics of these patients in order for this device to work. Yeah. But anyhow, we have sometimes to pay the price of bleeding. So what was in this trial?
Yeah, that's the Achilles heel, I would say, of the specific device. At least until now, we don't seem to be able to bulge from that 25+%. And you know, you can see here that the performance goal was 26.5%. You know, we didn't really deviate that much, but it's higher than danger shock. And you can argue, you know, it's a big number if 1/3 of your patients actually suffer from bleeding. And you can see here the breakdown that, you know, probably 1/3 of them in the treatment arm were access site related. And you can see here the distribution of the bark. But then again, for me, that's another weird situation where, you know, you have on the one hand side a device that has proven in animal models to work, and, you know, it has also given me a great case example in that CTO case that I told you, and it's trying to minimize your infarct size. But then on the other hand, you're dragging it down by probably the high ischemic time, the really high MAPs, the tachycardia that you're not tackling, and obviously losing hemoglobin, which is the carriers of oxygen. And I guess, you know, if you lose hemoglobin, your infarct size is going to go up. So it's like a little balance of your pros and cons. And what I guess happened in STEMI DTU is that these two things really balanced out absolutely perfectly. So I think the natural thing is that if we can get better on this side, then we will probably be able to see the benefit in the future.
Yeah. Before you conclude, I have a question to you.
Yeah.
So if you had to redesign the STEMI DTU, what would you do differently?
I mean, it's very difficult to criticize a study that had such a fantastic work going on beforehand. And, you know, it's very easily with a retrospectogram to make ideas. I think, first of all, I want to really openly congratulate the team behind STEMI DTU, because they've done a phenomenal work. And, you know, we learn from this and other trials all the time. Here we learned that, you know, probably ischemic time may have been a bit too long. We learned that probably, you know, having patients so hypertensive might not be a great idea. And, you know, having the heart rate they had is not a great idea, and trying to implement better practices with access and anticoagulation, because all these things are left to the investigators to do whatever they like. And as I said before, if you're using random anticoagulation strategy, you're going to end up with more bleeding, and more bleeding will take down your study results, or alter them at least. And I think these are very important variables to consider, and a little bit like the basis CHIP3 on the stable patients. Yeah, it was a comparison of a pump versus no pump strategy, but then we also saw that the revasc intensity was much higher on the pump arm, and that obviously counters the work of the pump. So there's a lot of things that we need to figure out, but the beauty is that these trials are really offering us the weapon and the armamentarium to keep fighting and go for future trials.
This is a field that is continuously evolving, and yeah, you said very well. Congrats to the investigators, first of all, to the indeed the team and the patients enrolled in this trial, because these are not easy trials to conduct. So we learn a lot from this. So what would you conclude? What are your take-home message from this trial, Vas?
I think we can easily say that at least the delay of 30 minutes with this device didn't reduce the infarct size compared to immediate PCIs, but also didn't lead in a higher infarct size. So I think that's an important takeout, despite that substantial delay of 47 minutes. And we did have a lot more bleeding, and this is something that we all need to concentrate either with practical tips and tricks, and all of us post the different stuff, and every time on the social platforms you see someone suggesting something different. But I think when you do that anecdote case, try to do more cases and then do a little study around it, otherwise it means nothing to the rest of us. So I think improving our practices is one thing, and then learning from the study and probably recreating it with different conditions that we mentioned before would be my take home. But personally, I was quite impressed that despite that massive ischemic time, we didn't increase the infarct size.
Yeah. Jan-Malte, and if you had to design a danger shock 2 trial, which patients would you enroll? What would you consider as a trial design?
I would say there's still a large patient population between STEMI DTU and danger shock on the other hand side. So what about non-STEMI patients? What about patients somewhere in between? So I agree with what Vas already said. I mean, it is not a negative trial. I mean, it's a hypothesis-generating trial for the next trial, and it's just a mosaic stone of the whole picture. We now know a little bit better and understand a little bit better. And as you already mentioned, the boundaries between high-risk PCI and cardiogenic shock are more or less fluent. So first of all, I'm waiting eagerly for the results of the PROTECT 4 trial, which hopefully will give us a signal that LV unloading and hemodynamic support is beneficial in high-risk PCI. But on the other hand side, I think this trial should stimulate us to better try to identify these patients that benefit most from hemodynamic support with Impella. So,
but for me also, it gives you that, the STEMI DTU gives you that security that a lot of people are stressed about, particularly in the shock cases, to go Impella up front. I think, if half an hour waiting in loading conditions that are not favorable for the device do not harm your patients, well, that for sure, when you go in a shock case, just put the device in up front, and that will actually benefit, because I don't think we highlighted the time study of the danger sub-study that showed that the faster you put that device in, the higher the benefits in terms of mortality. And I think that's an important message for the operators, not to be afraid to go Impella up front and then carry out their PCI, because time to unloading is really, really important, at least for now in these shock patients.
So I think that we learn a lot today, and we learned that we have to select the patients, that of course the routine use of MCS support in STEMI patients with cardiogenic shock should not be recommended, but might be indicated in selective populations. We also learn that the STEMI DTU rationale of course, has some basics, and the trial did not meet the primary endpoint. However, also paved the way for further investigations, and we are waiting for the next trials. And we hope that there will be investigators approaching your, indeed, ideas. I want to thank the speakers today. Amazing discussion. I think a lot of very good learning points and things we're going to use in our everyday practice. I want to thank the PCR team for the support from Johnson & Johnson for this webinar. And most of all, I want to thank the audience for staying with us and asking several questions. We'll also be addressing these questions later on. Thank you so much. You can see this webinar also later on. That will be on all PCR platforms. Thank you for being with us.